Simply Modified, we are shining a light on the complexities of dysphagia. In our series Dysphagia Bite, we speak with passionate individuals who are at the heart of dysphagia care to share their practical insights, emerging ideas, and real stories from the field. These bite-sized interviews are designed to inform, inspire, and connect us all in the shared goal of better mealtime experiences. In this Dysphagia Bite episode, we are joined by speech pathologist Natalie Grainger as we unpack what instrumental swallowing assessments are, why they're used, and what you can expect. A reminder that these interviews are for general education purposes and don't replace medical advice. If there's one message to take away from this, it's that dysphagia is highly individual, so be sure to connect with your own healthcare team for personalised support. Hi everyone, and welcome to our very first episode of Dysphagia Bite, your go-to series from Simply Modified, where I sit down with professionals who are passionate about making mealtime safer and more enjoyable. I'm Bree Simons, and I'm thrilled to be joined today by Natalie Grainger. Natalie is a highly skilled speech pathologist with extensive experience supporting adults with communication and swallowing difficulties. She has worked across a range of health settings and now practices alongside me at Network Speech Pathology. She is also the director of her very own Sydney-based private practice, SPIN, which stands for Speech Pathology in Neuro. Natalie brings a strong clinical interest in adult acquired and progressive neurological conditions, and she has a particular expertise in instrumental swallowing assessment, something that we're going to dive into today in today's episode. So let's get started. Welcome, Natalie.
Thank you for having me, Bree.
It's okay. It all seems very... Yeah, it's nice to have you here. It all seems very formal, but only because you have so much expertise, I had to drag you into this as well. So we're going to get started by talking about instrumental assessment, something that you're very passionate about. Let's start with the basics. What is a VFSS and a FEES, and how do they help us in understanding swallowing difficulties?
Yeah, so a VFSS stands for Videofluoroscopic swallowing study, so quite a mouthful. And a FEES stands for a flexible endoscopic evaluation of swallowing. So these are both specialised instrumental assessments that speech pathologists use to actually see what's happening with your swallowing. So a VFSS is essentially a moving X-ray where we can see the whole process of the swallow from different levels. So we can see it from a side angle and from an anterior-posterior, so front view. And that allows the clinician to essentially see what's happening with the food from your lips all the way down to your swallow. A FEES, on the other hand, is basically a very small camera that goes through the nose, and it dangles down and gives us a bird's eye view of your pharynx and your larynx. So both of these are very useful and extremely important to understanding swallowing difficulties. So a few things that they allow us to do is they allow us to ask very specific clinical questions. So we often want to know, is someone aspirating? Is food and fluids going into their lungs? And what can we do about that? And what's someone's response to that? So is their cough actually effective? Or, does food or fluids up in the throat, and does that increase with time or with fatigue? So we've got specific questions that we can have answered through these, because we can actually see a live swallow. They also allow us to pinpoint exactly what's going wrong with the swallow or where the breakdown is occurring, which then we can apply to. So things like postural changes, we might look at changes to dosage or cues, and look at how the anatomy actually impacts the swallow. And then we can devise a very specific rehabilitation plan, because not everyone is going to be suitable for the intervention. So for some people, they need skill-based training, some strength-based. For some people, we need to focus more on accepting risks and making informed decisions. And some people need airway protection. And so it's a really tailored approach to be able to capture what their swallow is doing, provide a baseline, but also check for any deteriorations. And then I think lastly, one thing that I really love using instrumental assessment for is for the teaching element. So it allows us to give that real biofeedback to a client so they can actually participate in the process and better understand their swallowing so that they can engage in the therapy, which makes it so much easier because they can see what's actually going on. So yeah, in short, both of them are extremely important, but they're not just diagnostic in nature. They're quite dynamic tools that really shape and allow us to improve treatment options. But it's important to note that one doesn't necessarily replace the other.
Yeah, big time. And something that you mentioned there is that you're right. It's not just a 2D image. You know, the imaging that we get for broken bones and things like that is so different to what we would use for something like swallowing physiology. So the way that the swallowing muscles are working and that movement requires a moving image. So the VF providing that moving type of X-ray, whereas the FEES with the scope down the nose, it's that kind of ongoing image of that swallow. So that as speech pathologists, you're right, we can give that immediate feedback to the patients or the clients, people with dysphagia, to say, look, this is what we're seeing. And can you notice it within yourself as well by looking at the image alongside them as well? Brilliant. So at the end there, you mentioned they don't kind of replace each other, but I guess how does one choose? What's the difference when you go, okay, this person will be perfect for a VF versus another type of patient that maybe would benefit from a FEES?
Yeah. So that's a really common question and a good question to think about. And I think they're both, they don't replace each other, and they're both gold standard treatment options, assessment options, sorry. And so it really comes down to what your clinical question is and what it is exactly that you're looking for. So it's always important to obviously assess the benefits and the risks because they are very different tools. So thinking about a VFSS, a swallow X-ray, that's going to look at capturing that entire swallow process and look at how the different, how it follows the journey of the swallow, it follows the journey of the bolus. So the food, everything from the lips to the mouth to the teeth to your palate to the back of your throat. So we're getting that oral, that pharyngeal and the upper esophageal elements of the swallow and how they kind of interplay and are connected. Because when we look at observation-only studies, we're often looking at different parts of the swallow in isolation, but that's not how the swallow is, a sequence. And so when we get that person to eat and drink the barium, we're actually looking at movements and the structures and how the flow of the food gets cleared. So that is quite important for identifying structural abnormalities as well, because we're looking at both sides, but a front-on section as well. And so in order to really assess the swallow biomechanics, you really do need a video fluoroscopic swallow study. And as well, if you're thinking this is an issue with timing, then you need to do a video fluoroscopic swallow study. A FEES, however, gives us really close-up 3D colour image of your larynx. So with an X-ray, it's black and white. You're not really able to, you can see secretions, but you can see much better in a FEES. So you can observe those secretions, you can observe someone's response to the secretions. You can have a look at pharyngeal movement in really getting a good view of that, looking at residue. It's very clear penetration versus aspiration. It can be difficult to see that sometimes on a VFSS. And we can also look at the colour, the symmetry, and we can assess sensation. So that clinically gives us really good information about someone's risk and the risk profile that might cause, increased risk of hospitalisation infections. So I guess some of the other factors would be things like timing. So, both of them are real, but there is no time limit on a fees. It can be done repeatedly where you do have a radiation exposure and a specific time limit to get the assessment done. And there you are using the barium as well. So a little bit more flexible in terms of assess the whole meal, and you're not having to mix things with barium that change the actual consistency of the food.
I'll just touch quickly on what barium is there. You've mentioned that a few times, and obviously it's integral. Can you tell our audience what is barium and why is it so important in these assessments?
Yeah, so barium is a contrast agent, a safe contrast agent. It's a little bit chalky, tastes a bit like toothpaste, and it's mixed into the food and the fluids. So that when the X-ray pans on, we can actually see the food and the fluid and exactly where it goes and what's left over. Likewise, in a FEES, we don't use barium. However, we do dye things. So you would dye something blue or green or white because there's nothing in that area that is that color. So we can very clearly see that something's there left over where it shouldn't be, and distinguish that between other structures. Mm-hmm. Yeah, so look, both are really quick, and they're usually very well tolerated. So when it comes to the swallow X-ray, you're essentially asked to sit in a chair, and you'll be swallowing different textures of food and fluid with the barium in it. And there'll be an X-ray machine. There'll be some quick instructions that you need to follow. And that's really it. You don't need to prepare. You don't need to be meal by mouth. It's not invasive in any regard. Usually about half an hour in length. A FEES, obviously that small camera is going through the nose. And the most, I guess, essentially it records, there's a light source whilst you're swallowing. It's definitely not painful, but it can be quite tickly and it can be uncomfortable. So a lot of people will sneeze while it's happening. Some people will gag because the camera will touch their gag reflex. And so, I would say that, your clinician will talk you through the risks and try and keep you comfortable as possible. You most certainly can have your support people around you as well. So you, certainly with FEES, there's no radiation exposure. You can do it anywhere. You can have as many people there as you like or don't like. And then you can usually have one or two people depending on the provider and how big the room is and things like that. So, it can be a little bit uncomfortable with these, but it's very quick.
Yeah, and I guess that's something you're touching on there as well, is the fact that there are FEES services, and I think you are one of the wonderful providers around Sydney that offer it too. But as a mobile clinician, starting to explore completing those assessments at someone's home. So making someone more comfortable, because it tickles, it's not every day that you have a little scope put down your nose. So it makes sense to be able to do those in areas that you are most comfortable. And I guess coming back to that, okay, should we choose a FEES versus a video fluoro swallow study? Maybe some people don't want to go to hospital to have that assessment completed. So maybe a home-based option like FEES is more suitable. Definitely.
Yeah, and I guess it's important that, like, as clients, you have that really open discussion about, anything that you are nervous about, because there is often a little bit of anxiety around these particular tests, but a lot can be done to make sure that they're working in your favor and that they're meaningful for you and comfortable for you. So that might be, limiting certain textures in the assessment, or it might be that, we do a small FEES to have a look at secretions, and then we do another one later, or things like that. So
Yeah, they can vary person to person. Big time. Okay, so how can someone get a referral for either of these tests in Australia? What does it tend to look like in terms of that referral process? Is it direct to us as speech pathologists, or does it require a different route?
Yeah, usually the referral comes from the speech pathologist. If it is if you're going down the route of a swallow x-ray, then a GP or a specialist does need to sign a radiology request form. However, most of the referral would come from the speech pathologist. So if you've got someone that you're working with, they can initiate that referral and work out what's going to be the best assessment for you. Yeah.
Okay. And what does that look like at the moment in regional and rural parts of Australia in terms of access to these tests?
Yeah, so I wish that all of them were available everywhere, but they're not. Access does vary quite a bit. Certainly they're both pretty widely available in most metropolitan areas. In rural and regional areas, it's really site specific. So most tertiary hospitals, public acute hospitals would have a videofluoroscopic swallowing suite that you could get a referral to. And then mobile fees practices, they are popping up. But they're less common. But certainly they are available in outpatient departments. And sometimes you do see fees alongside an ENT. So an ENT clinic may have a speech pathologist that they can run that procedure. It's not very common to see a videofluoroscopic swallow study done in just a regular radiation clinic that you would typically go to for an ultrasound or a regular x-ray. So they are all specialised. They generally need to go to a hospital or an outpatient clinic department.
Yeah, an ENT, they're standing for ear, nose and throat specialist. That's right.
Yeah.
So we've kind of alluded to some of the risks already, but is there any other risks that people should be aware of beforehand?
Yeah, look, both assessments are very safe. There are different contraindications for some. So a contraindication, for example, or a risk for a fees would be something like a recent base of skull fracture, a nasal, or maybe you've had a head and neck tumour that's still quite acute in nature. You might have a very narrow airway. So those things sometimes need medical clearance, or someone who has quite a severe history of epistaxis, which is really severe nosebleeds, with fainting, for example. That might be something to consider, but typically they're still quite low risk. The most risk for fees is patient discomfort. So they're a little bit funny. It feels a bit funny. And we don't numb the area because we need to see what your sensation is like, because we need to see your swallowing. And then I guess with a videofluoroscopic swallow study, there is radiation exposure, but it is quite it's sort of comparable to, say, like a dental x-ray. And when they looked at studies comparing that to general population and the general population's exposure, and it is quite minimal. But again, it's just important to obviously discuss these with your provider, with your team, with your medical team, with your speech pathologist, so that the risk can really be well explained, and then you can make sure the assessment fits into your goals. Yeah, definitely. And as you say, if the goals are so orientated about, okay, let's investigate what's going on first off, but also in a dynamic way, okay, we could use this as a tool to show you what's going on, give you that biofeedback to make those goals work. As you said, it's not just an assessment tool, it can also be a really good therapeutic tool for some. Going into it, is there anything else you'd like people to know before they get an instrumental assessment if they're feeling a bit nervous or maybe a bit apprehensive? I think Look, I think it's completely normal to feel that way. And I think just be really, have a chat to your team before. The choice is always yours. You always have the option to say, look, I just don't think I want to do this today. But certainly, I think they can sound quite technical, and I think we do a really good job sometimes of talking too much and telling you probably too much the technical information that can be quite intimidating. But really, they're very quick. They're quick, they're low risk. It's not like having an operation or a day surgery or anything like that. They're run by professionals, and they're run by people who have certifications in these particular studies. So it does require an advanced level of dysphagia management. And so the people who are running them all the time. Most people, they are surprised at how quick and kind of empowering it is to actually get the answers straight away. I think there's a lot of people who leave the assessment and think, I was really worried about that, and now I actually know that it's not that's not an issue, or actually it's this that's an issue, and they're able to make more informed decisions because they actually know. So we often are able to upgrade someone, and then they've been on a restriction for quite a while, either out of fear, or maybe they had an acute change many years ago and they've never actually had any speech pathology input from that. And so you see them and you're able to actually give them really objective information. So,
it's definitely
choice, but it's they're very good assessments.
I agree, and particularly allowing patients and clients to know about the fact that clinical swallowing observations without instrumental assessment are actually just, most of the time, they're guesswork. I know it's informed guesswork. Speech pathologists, we undergo a lot of training to make that guesswork happen, but without that instrumental swallowing assessment being completed, we're really just hypothesizing about, okay, this could be this, it could be this, but without that instrumental assessment, we actually don't know. So as you said, sometimes someone comes into an instrumental assessment and it's actually good news, because the very conservative approach that we had to take at the clinical swallowing observation, which just means when we're watching you eat and drink, we're taking in all those cues. But then to say, okay, I'm going to put a conservative approach down. We've agreed that, you're tolerating this with less discomfort, so maybe more of a minced texture or a mildly thickened fluid. But then by the time you actually get to the instrumental assessment, it's like, actually, you have the capacity to swallow this and this, and you're doing it really, really well. So we'll upgrade you, as Nat, you just mentioned there. So the upgrade means to bring yourself back to a texture that you've kind of been put down from. So maybe a regular diet and thin fluids. So it's not all detrimental, like, this is something we're seeing. This is an impairment of your swallow. It sometimes can be, no, actually you're in good hands. You're doing really well. So really good tools, and so necessary to take away that guesswork that so many of us are having to do with the observational swallows.
Yeah. And like I said as well, to devise a therapeutic approach, not everyone is going to be suitable for strength-based training. That can actually do more damage. And often we see people prescribed with a particular exercise, and then when we actually see it live, it's actually pulling the wrong muscle, which is having a contributing factor on something else in your swallow, which hasn't been identified because we've just observation-based studies. So, we can certainly, there is obviously a big scope and practice for swallow evaluations based on observations. And we know certain aspects of swallowing occurs in certain conditions as well, so we can make clinical judgments on that without instrumental assessment. But I think more people should have an instrumental assessment. And people should know that they are accessible and available. Yeah.
Pending availability in the area and things like that too. But yes, I agree. The gold standard is there for a reason.
Yeah.
Okay, so a few more questions, Nat. How can these tools really make a difference? I know we're talking a lot about like the aspect of someone's swallow, but what if we talk about the bigger picture here, the quality of life? So what can these instrumental tools do in terms of making a difference for someone's quality of life?
Yeah. So I guess the studies are designed to give you meaningful, real life results. So, I think they're not just for the clinician. I think we've all been in a situation where we've been recommended a test or recommended to see a professional, and we think, it's not going to be of much benefit. But we do try and apply really tailored approaches and strategies so that you can get the best out of your swallow, because we are eating and drinking multiple times a day for the rest of our life. And so we need to be able to make decisions that impact how we do that meaningfully and also safely and comfortable. So it's not just about the food and the drink. It's not just about, texture modification. It's actually about dignity and safety and quality of life and preventing any serious complications like hospitalization or weight loss or a deterioration in someone's muscle function that impacts their respiratory condition, impacts falls. And so we want to stop that vicious loop. And this is kind of an ability to guide people to make that tailored therapy choice, but also empower people to make informed choices that impact that, because we're actually identifying where the swallowing problem is occurring, and we can either target that or we can inform someone about what's happening, and then they can choose whether they want to target that or not. But we actually know if there's even a problem in the first place. So I think there's often a lot of people doing a lot of guesswork and potentially treating coughs as the only sign of dysphagia, and people are on a lot of modified diets that may not need to be on that. And so, really regaining a lot of people's confidence because they can actually see it for themselves as well. So I think the right assessment and allowing that instrumental assessment to be part of your toolkit and advocating for that can be a real turning point in your swallowing journey.
And I don't doubt that so many people who will be listening who might have dysphagia may not have even heard of these swallowing assessments. So hopefully this provides them with a little bit more information to say, yep, these tools are available. Some definitely more accessible than others depending on your area, but definitely advocate for yourself. If you feel like this is something that's relevant for you, reach out to your speech pathologist or your GP to say, okay, this is something that's going to be worthwhile, and explore it. Okay, Nat. So lastly, tying this into all things Simply Modified, what is a favourite food of yours that can be simply modified for someone experiencing dysphagia?
I'm a big fan of like chickpeas and lentils. Like hummus is just like a household staple for me. So I love that because it can be, they're quite cheap. They're easy to store. Like you can get them in dried bags. You can get them in cans. You can puree them. You can mince moist them. I don't know if that's the right terminology. And mash them up so that they're really easy. You can add extra moisture. You can have them whole. You can have them roasted. Like they're just so adaptable. And obviously I'm no dietitian, but like they're very good for you. So I think I know you have a lot of recipes in there that use chickpeas and lentils. And so, I think those are kind of that. And I would say like sweet potato as well. Yes, big ticks for me, both of those, big time. Nothing better.
Thanks, Nat. Well, okay, I'll give this a little wrap up. So thank you so much, Natalie, for joining us today. If you have found our discussion super insightful, be free to share. We would love to also know your comments. Is this something that you've experienced before? What did you think of your instrumental assessment when it happened? Or if it's not accessible in your area, let us know, and we'd love to see if we can get instrumental assessments as the gold standard across all practices for speech pathologists working in dysphagia. So thank you, Nat, and thanks for everyone for watching.
Thank you.
Thanks for joining us. Stay tuned for more episodes. And remember, dysphagia is different for everyone, so reach out to your healthcare team to find what works for you. Check out the Simply Modified Whole Foods Cookbook for more dysphagia inspiration, or you can reach me at Network Speech Pathology.